hypermobility of the pelvis and spine is fixed when you fix the hip. The hip couldn't participate, couldn't work. Now it can. So the mechanics, the body has this way of wanting to get back to homeostasis, to natural movements. It's again in part of this kind of compensation world that goes beyond basic mechanics. That's so absolutely fascinating about studying the human body. I mean, at first I started this so I could learn where to put a cup and get hip replacements better. But I was learning about the human body in ways that nobody seems to know, and because I looked across the junction, I crossed the barrier between hip and spine. And I mean, it's been so rewarding.
Welcome back to another episode of the Spine Pod. We are in Maple Park, Illinois.
We are. We're sitting in Maple Park, Illinois, just outside of Chicago, with a legend in the hip space, in the orthopedic space, and coming soon, and is now developing in the spine space.
In the spine space.
Dr. Russell Bodner. And what an honor it was to sit down with him here in his home. Just incredible, the amount of insights, the amount of work, everything that he has done. This is a special one.
I was really excited for this episode because I've been following Dr. Bodner on LinkedIn for a while now. And I like to take my popcorn and sit and just read what he has to say because it's just absolutely fantastic what he's doing, connecting the ideas of hip and spine together. And we're a linkage system, and we don't talk about that enough in the industry. And so to be able to bring in a hip surgeon with as much research knowledge and passion as he has to talk about these conversations, I feel really lucky that we got to sit down with him.
Absolutely. I think historically it's very easy, whether you're a patient or the way we treat these conditions is we treat them separately, right? And the truth of the matter is we know that they move together. We just didn't understand or value to what extent, right? And so now we know the way the spine moves and the way that we construct or reconstruct the spine or how it fails to move can impact the pelvis, can impact the hips, can impact your knees. And those are things that are not always talked about. So when you're a patient and you're having, concomitant conditions or you're having hip spine syndrome, you sometimes don't know where to go. And Dr. Bodner does know where to go, right?
He knows where to go. He sure does. And it is absolutely fascinating. And it's so important. This is what this podcast is about, having conversations with those innovating on the edge, saying, how do we push the standard forward? And he takes us there. This is a long, really, really in-depth podcast, and it is so juicy.
Absolutely. It is a Joe Rogan-esque podcast. I mean, it has got some length to it, but every minute is worthwhile. It's great to hear when someone has had a career like he has, how it was built, right? And the different inflection points in his career and why he's focused on the things that he has. And he tells us stories about his parents and Dr. Richard Stedman and Dr. Larry Dorr and all these really influential pieces in his life. And you can see why he's had the impact that he has and why he does the work that he does. And he's been doing this for 35 years and he still has the fire. He still has the light in his eye. He's still working to make an impact. He's still giving back. I mean, it is amazing the work that he has done and what he's been able to do. And I think we just can't wait to see what he continues to do in this next phase of his career.
Absolutely. It goes back to a lot of life purpose. And it's fun to sit down with somebody who really has found their life purpose and has a fire and a drive for it. So it was great to talk to him about that. And the idea of perspective, of sometimes you need an outsider's perspective to answer the questions that you're having a hard time solving. And I think that Dr. Bodner is going to be a big impact for spine and a lot of the big questions that we have been struggling with for decades and how we're going to fix them.
I think he already has been, right? And he's just on the beginning side of what that's going to look like and how that's going to influence care and how that's going to influence multifactorial care, right? And so for patients and for the spine community, I think we're going to be very fortunate for the work that he did, and the work that he is continuing to do. And if I ever find myself in that position, I think I'm going to be very thankful for the work that he's put in. And so it's been fun to watch his career, and it's going to be exciting to see what he has left.
And not only that, we had a very special guest in this episode.
We did.
Leo the cat joined us, when he wanted to, a couple of times. So he's also, if you're watching this on YouTube or on Spotify, you get to check out Leo the cat as well.
Absolutely right. Well, let's jump right into this one.
Enjoy this episode with Dr. Russell Bodner.
Dr. Russell Bodner, it is a privilege to sit down with you. Thank you for hosting us and taking us in and sitting down with us today. Thank you. We really appreciate it.
Oh, you're welcome. And thank you for coming out to my home and doing this.
Of course.
We're so excited. We drove up and we're like, oh, it looks like there's a lot of fun toys to come check out. So we can't wait for this to be over too, so you can take us around and see all the fun stuff you've got on your property.
Yeah, I'd be happy to.
It's awesome. Well, we got to do a little bit walking around. We're in beautiful Maple Park, Illinois. Is that where we are?
Just outside, unincorporated Kane County.
So just outside of Chicago here in some beautiful farmland. But, setting the stage, we are very privileged. We appreciate you taking the time. Someone that spans so many disciplines, as an orthopedic surgeon yourself and 35 years in practice, and you've done it all and you've seen it all, and you've worked with truthfully some of the best, right? The legendary names and people that we know well, and you're very well known. And I want to set the stage because we're a spine podcast, right? And we talk to spine surgeons. And I think you could get asked the question of, why are we sitting down with someone who is focused in hips and lower extremities and knees? And I think we want to make the point of how tied in those things are and how all those components work together. And that's why we're sitting down with you today, because you could argue there isn't someone that's doing more research in this space on spinal pelvic alignment and total hip arthroplasty and planning and analysis and outcomes than yourself. And so we're very excited for this conversation. We appreciate you sitting down with us and taking the time. I think this is going to be a really exciting one. So later on in your career here, you have made massive, substantial impacts on the hip community, on total hip arthroplasty, on planning, analysis. Was that something you focused on throughout your career, or were you more focused on knees or just doing general work, or did you get more niche as you moved along? How did that work for your career?
Well, I was a sport guy who enjoyed doing primary joints. And I was fairly well exposed to joint replacement in my training. I was one of Dr. Richard Rothman's last residents before he left University of Pennsylvania to become the chairman at Jefferson in Philadelphia. And he became a legendary figure, with the Rothman Clinic being a giant organization. And when I was with him, there was 3 guys at Pennsylvania Hospital. I mean, that was it. And we had Paul Lotke at the University of Pennsylvania, who was a very well-known knee replacement surgery. And I think I felt very comfortable in practice doing primary total joints and simple revision work. But my exposure to this hip spine and hip replacement surgery occurred rather abruptly. I always was concerned that my cups would not be where I thought they were. The way we used to do it is do your surgery, patient goes to the recovery room, you take an x-ray, and that's where you first find out what you did. And sometimes it didn't look the way I thought it should look. And I always worried and wondered about that. And in 2015, I actually ran into a booth at the Academy meeting in Las Vegas, where an engineer told me about taking x-rays from the side like spine surgeons do in the standing and the sitting positions, measuring the mobility of the patient's pelvis and then planning the cups to match that person's individual mechanics, which was mind-blowing. I mean, it just was not in our teaching at all.
I want to go further into that. But before we do, can you explain what cups are when you're talking about that for those who don't know? What does that mean?
So a cup is the component of a hip replacement that goes in your pelvis. There's a part that goes in your femur and a part that goes in your socket. And the acetabular component that goes in your socket, we refer to as a cup.
Okay, so it's where that connection happens.
It's a ball sitting in a metal cup with a plastic liner or bearing.
You got to work with one of the legends and pioneers in hip, right? So you got to know and work with very closely with Dr. Larry Dorr. Do you want to talk about the inception story of that and how you started working with him and you got to know him?
Yes. So I got indoctrinated at the Academy meeting. And then I went back and I started reading everything I could on this topic of functional planning for hip replacements. And I finished my readings and this is awesome. And a lot of this was spinal biomechanics that was produced by French spine surgeons. And when I tried to apply it to hip, there was no guidance. There was nothing except one paper that I found it was in JBJS in 2014 that was written by Larry Dorr, a very well-known hip replacement surgeon in Los Angeles. And I decided that I was going to call him up and see what he was doing and seeing if I could help in what he was trying to accomplish, because this is what I wanted to do. And he engaged me by email, and we started emailing regularly and debating different things. And it developed into a collaboration that lasted nearly 4 years.
I think that kind of sets the stage of why this is so inherently important. And we talk about this a lot with the surgeons that we sit down with. And it's adjacent segments, it's mobility through planes, it's malalignment, both in the sagittal and coronal plane. And I think the work that you have done and continue to do talk about how all those features work together, right? And when we talk about adjacent joints, it's really easy in the spine to say, L4 is adjacent to L5 and L5 is adjacent to S1. But the truth of the matter is the next adjacent joint is the hip, right?
That's right.
And so you get these conditions and this adjacent work and this compensatory mechanisms, they occur across that entire platform. And when you sit and when you stand and when you move, it occurs not just in the spine, not just in the pelvis, not just in the hips, but all together, correct? And I want you to set the stage for why that's so important and how the body as a kinetic chain moves as one, and they're not separate components, rather they're components that work together.
Actually linked. And there are, you could say, ratios of movement. If the pelvis moves this far, the femur or the hip joint moves this far. And so there's biomechanics at work here that I set about to try to quantify the biomechanics linking the pelvis, which is linked to the lumbar spine, and the motions of the hip. I mean, patients know that we're linked, but
they feel it, right?
The subspecialists don't. The hip surgeons work in a world that was defined by an AP view of the pelvis. static, not moving in space like a receptacle to hold a cup. That's it. And the spine world only worked in the standing position, and most of their corrections were based on the lateral X-ray. And so they really had different languages they spoke, different philosophies, dogmas, separate, even though there's no separation whatsoever. A patient would go see a spine surgeon for a problem, and he'd say, well, you better go see the hip surgeon. And the hip surgeon would say, oh, I think that's the spine. Go somewhere else. Mm-hmm. Nobody really thought in orthopedics to treat people as one connected person or learned how the machinery actually works.
It's wild when you say it because it's like, well, that makes so much sense, right? It's like, of course you would. You would look at it holistically. But it, like, to your point, you're like, till 2015, that was the first time you talked to an engineer. I was like, oh, wait, that makes sense. It's kind of wild. Like, as a patient listening, I'd be like, how did we get this far into medicine and we didn't realize that we're a linkage system and what you do on your spine is going to impact your hip, or what you do in your hip is going to impact your spine?
I thought the same thing. So because I was not an arthroplasty fellowship trained doctor, and I was older, I felt I was free to go where I needed to go. So I read these papers that were very exciting papers coming out of New York, especially, that was quantifying these angles and how the spine worked, and then trying to tie it to what Dr. Lazenac in France was doing with the EOS machine on hip biomechanics and pathomechanics. So the groundwork was laid, but the challenge was to actually bring it together.
You know, I'm envisioning, you know, those big boards when you have a crime and it's like the red tape that's like you're trying to connect all these pieces. That's what I'm imagining you doing, is you're taking all of these different research papers and data points and like kind of coming together and figuring out, like, how does this work? Like,
what is exactly what I did. Data. I needed data. And Dr. Lazenac produced data, and Dr. Dorr produced data that I could use in my mathematical or biomechanical analysis, not so much a cohort of data points, but to try to figure out the mechanisms and the actual biomechanics of this.
You know, we hear a lot about hip spine syndrome, right? And how they're so interlinked. And I'm curious what kicked you off to make this a worthwhile pursuit for you, where you saw it and you said, this is a problem that needs to be solved. You know, when we look at total hip arthroplasty and we see a lot of the data surrounding dislocations, right? And a lot of that occurs in conjunction with certain spine care that occurs. Was there an event or time or a data point that you saw where you said, this is a problem that really needs to be solved?
Well, we knew it coming from the hip side, that stiff spines or malpositioned, imbalanced sagittal balance, you know, as spine terms. If the pelvis was cattywampus standing and the spine was malaligned, that also was a problem. And hip surgeons recognized what they called pelvic tilt issues for well over 20 years, but in a different terminology for it. There's two types of pelvic tilt. We use the anterior pelvic plane, hip surgeons, not the spinal pelvic tilt that goes along with sacral slope and pelvic incidence. I used all the intrinsic spinal parameters where it all fit together and made sense.
When you're talking about that, so I think this is a really important topic. When you're talking about stiff spines and how it changes the pelvis, what is actually happening there? So for patients that are listening, because this is what happens, right? And you can have a stiff spine just through general pathology and degeneration over time. You can also have a stiff spine through a fusion, right? And so what is the actual mechanism that's occurring that the spine is changing the pelvis?
There are two parts to it. The most commonly used part is the lower lumbar spine that attaches to the lumbosacral junction. How much does that lumbosacral junction move with positioning or functional positions between standing and sitting? That's when you sit, you're mostly just moving your pelvis, and the upper lumbar spine stays erect because you sit erect and you stand erect and you just are flexing to sit down. The changes that occur are mostly in the lower lumbar spine, where most of the pathology occurs, L4-5, L5-S1. And what happens when you get degenerative change? Two things happen. One, you lose your lordosis, so you're not standing up extended. You begin flexing over. And second, you lose the ability to change the position of your pelvis when you sit. Normally, when you sit, your pelvis rolls back and basically allows your femur to flex up. It doesn't stay forward like you are standing and cover the femur. It allows the femur to come up. When you have disease in your lower lumbar spine, the pelvis can't roll back. So the femur does most of the work. It has to compensate. So besides normal biomechanics that I had to learn, you have to learn the body uses compensation strategies so you can live.
Mm-hmm.
And that was absolutely fascinating. And unless you studied both sides, you didn't really get it.
And how complex does that get with like each individual can be compensating in a different way, right? There's probably things that you tend to see, but as an individual, I might compensate very differently depending on what's going on in my low back, right?
Absolutely. So your postural system is defined by the way your pelvis is built. And this is measured most commonly by pelvic incidence. When you have a higher pelvic incidence, then you have more lumbar lordosis. When you decline, people with high lumbar lordosis, their whole spine begins to straighten, not just the bottom. So they lose a lot of lumbar lordosis. Whereas a low pelvic incidence, most of the change occurs only at the bottom. Most of the lordosis of the spine is at the bottom. So not only are you built different and work different, you decline differently based on your individual body.
As we talk about a stiff spine, what is the importance of a stiff spine and how it affects the hips?
You have to sit. Your body has to sit. So if your spine can't accommodate things, your femur becomes almost one-to-one more mobile. And the problem in sitting, if the pelvis can't roll back out of the way and the femur is coming up more, the femur will begin to impinge on the pelvis. And most of the time, it's actually the trochanter, a part of the femur, that hits the pelvic bone and causes that impingement to occur. So if you put a hip replacement in that environment, when you sit, the femur still comes up because the spine isn't improved by a hip replacement, but the hip is. It can flex more, and it does. So it comes up, hits the pelvis, and it begins to lever that ball out of the socket. So when you flex or bend over, it will come out the back of the socket.
These are a lot of complex topics here.
Yeah.
So you're talking about, when you talk about the retroversion and the anteversion of the pelvis, essentially what you're saying is you sit down, your pelvis rolls back, right? Your pelvis retroverts. As that happens, compensatory effect of your hip is that your femur will then roll forward and you could get that posterior dislocation. That's essentially what would happen in that situation.
Yes, the pelvis doesn't roll out of the way. The femur is hypermobile, and they just bang into each other. The highest risk factors for dislocations are spinal imbalance, sagittal spinal imbalance, because these people are way off, and stiffness is the second. So a stiff spine makes a hypermobile femur.
If you're going to sum up two problems that spine surgeons are trying to solve, that's two of the problems that we're trying to solve, right?
That's it. My research can be summed up by saying the position of the acetabular component is passively determined by the standing tilt and mobility between standing and a flexed position. The cup position is passively determined by the pelvic biomechanics because the pelvis houses the acetabular component. And so my geometric calculations to find the optimum place is based on understanding these angles and how they change. It's passive. It's not the traditional. The surgeon would say, well, I like my x-ray to look like this. 40-20 will call the position of a component based on the inclination angle on an anterior x-ray and this other angle, which relates to more the sagittal position of the cup. There are these two numbers. And the surgeon would always predict and try to put it that way in everyone. And it's absolutely wrong. But in 85% of patients with normal mechanics, the tolerance or safety built into the components that we have are such that it doesn't really matter. You don't have to hit the bullseye if the spine is doing its job, the pelvis is doing its job, and the femur is doing its job. It's a combined integrated function. Usually your femur only moves 55 to 70 degrees because your pelvis is moving 15 to 20 and your spine 20 to 25. It's a perfectly coordinated system. But all this has to do is in understanding what happens when the system breaks down. It's fascinating.
Let's stick on that topic because you're saying when there is normal biomechanics of the spine, this is what is supposed to occur in the hip, or you can hit this area in the hip. But the truth of the matter is we know that concomitant conditions through the hip and spine occur in a ton of patients.
Everybody.
Right? So we're essentially saying like for the minority where like this is what's supposed to happen if you have normal biomechanics, but if you're coming in for surgery or you have pain, a lot of the time you don't have normal biomechanics, right? So now you're treating a system that is not moving the way it should. It's stiff or you have sagittal malalignment, and then you have spinopelvic parameters that are not going to match whatever system you have in that regard.
Another aspect of this is that hip surgeons have always used anatomic landmarks when you put your cups in. Unfortunately, those anatomic landmarks move when the patient gets off the table. So we spoke a little bit about the problem when you sit with a stiff spine. The problem with spinal imbalance can be in standing. When a patient is supine, the pelvis is in one position. Gravity is not working on that patient. When they stand up, the imbalanced people, the pelvis rolls back. It's the primary compensation mechanism for imbalance. Basically, you want to bring the gravity line or SVA that surgeons in spine world use. You need to bring that back. And the way the body does that is it rocks the pelvis back. If you put a cup in to anatomic landmarks, that patient goes up, the pelvis rolls back 20 degrees, you've changed the anteversion, which is the important component parameter, 15 degrees. So you can actually create a situation where in standing, the cup and the femur impinge with hyperextension, standing or extending your hip with external rotation of the hip, and you can impinge on the other side than the sitting side.
It's a great topic though, because this happens, right? I mean, you see so many patients that don't come in and just need a single hip replacement, right? A lot of times they have spine pathology as well. And so they're getting seen by multiple specialists. How do you solve that problem then? Are you saying that the spine and the changing biomechanics of the spine in a degenerative case or in a sagittal malalignment case affects essentially how the pelvis and the hip will function after that?
Absolutely. And it's proven that hip arthritis occurs faster after spinal surgeries where you lose motion. If you're impinging with a hypermobile femur, the hip joint is doing too much and it'll wear out faster. It's adjacent segment disease.
Isn't that so crazy?
It's the next adjacent segment.
It's so crazy because we think about those as separate component parts, but it is just, we talk about ASD and spine all the time, right? It's one of the biggest, ASD and PJK are probably two of the biggest problems that are trying to get solved right now. And it's no different. It is ASD for the next adjacent segment. It just doesn't happen to be in the spine, but they should be treated the same way.
Well, and the way that we're siloed out, as a spine surgeon, you might not even know that that's an issue because your patient's not coming back to you about that. They're not even connecting that it's actually potentially the fusion that you had that is causing you to have the next level of degeneration.
The latest trends in spinal fusion is to not leave them in undercorrection, to get the lordosis on an individual segment level correct. So the issue with that is that changes the pelvic position. And if a cup is already in place, can cause a well-functioning hip to malfunction and even dislocate. So that's one issue. The second issue that I want to say is I spent years seeing patients who weren't surgical patients, who would come in with complaints around the butt and low back and the thigh, and you couldn't tell, is this hip or is this spine? So I would do the same spinal pelvic analysis that I did for joint replacement planning on people, regular patients. And I began to learn the patterns. And I would say, the x-rays speak to me, because I could see the compensations that patients were doing. You asked, how do you know? I could see how they were using their spine or how their spine didn't work. Not just pathology, not that you just have a bad disc, not that you just have a little grade 1 spondylolisthesis here. It's not pathology, it's mechanics. It's how is this person's body working? And I could really appreciate the challenges that the patients were going through because I could see where it was coming from by the mechanics, functional x-rays.
And I think the functional component is such an important one, right? Because you have two aspects of when you're providing care. We have a pain removal aspect, right? Which is we're trying to remove pain, get them back to a normal level. But the second part of it is being able to be functional in everyday life, right? When you're talking about sitting and bending and twisting, it's great to do in work, it's great to do in athletics, but the truth of the matter is, and you make such a great point, and we lose sight of this, is that we treat a snapshot in time, right? So we can say, all right, we're going to do, which is a fantastic technology, EO scanning, I think is doing wonders for orthopedic care. We can look at them and we can say, okay, here's the correct lordosis that we can put someone in, right? And we're going to fuse them L3 to S1 or L1 to S1, right? Which is great. And there are some patients that need that. But for the patients that don't, when you go and sit now, you have compensatory mechanisms happening. You've got the hips that are now compensating. You also have the upper spine that's compensating. And then you get those problems that occur down the road, right? You can solve a standing position, but we're not standing 12 hours a day, right?
That's true.
We're sitting and we're standing up and we're bending over and we're doing all those functional components. So you can make a case for motion preservation that you put something in that preserves motion, right? And then you don't have such hyperphysiologic loads or compensatory mechanisms that are occurring at those adjacent joints.
Let me tell you this. From my work, my numbers, the influence of pelvic incidence on cup position is small, 6 to 1. It takes 6 degrees change of pelvic incidence to make a 1 degree sagittal change in the cup position. Tilt, has a 4-to-1. So it's more important than pelvic incidence. It takes 4 degrees of a change in pelvic tilt. The perfect cup would change 1 degree. Motion is 2-to-1. The most important factor driving the position of a cup is the mobility. So it's important. When you fuse people, especially longer fusions, say 3 levels or more, fusions that cross the sacrum, screws going into the sacrum or screws going into the ilium, which are important so these constructs don't fail. They are making the hip absolutely hyperactive and can cause problems if there's a hip replacement already in. So my latest paper that I'm trying to get published is a call for spinal surgeons to analyze the position of a pre-existing cup when they're planning to move the pelvis with creating lordosis in their pre-op planning. Because if a hip dislocates after spinal fusion, it's not a happy situation. The patient has to be unhappy with the spinal surgeon because the hip worked before. The spinal surgeon cannot fix that problem, has to refer it to a hip surgeon who isn't happy to get this problem. And the number one cause of failure for revision of a hip for instability in this setting is recurrent instability. It's a tough problem to fix. So the key is to identify the high-risk patients in the planning process. So there are 2 resultants of that. The spinal surgeon can choose to change their plan, which I don't think that's going to happen much. If you're going to fix somebody, I think they want to fix somebody. The other is to have the discussion with the patient and say, we've identified this could be a problem. And that would go a long way for helping the patient make the right decision. And even sending that patient to the hip surgeon before so they're aware of the situation. But this is going to take a lot of education.
As you know, the work that you've been doing, it doesn't happen overnight, right? And you really have to work to get it out there.
It's almost generational. These types of things, like I said, the conservative management that I did, there's no one doing that. I've never given a class. I've never been able to share that because we're surgeons. They want to do preoperative surgical analysis. We work to operate. If we don't operate, we offload them to other treatment providers. So that part of it may go with me, so to speak. And the surgical education, it really has to, I think it has to be driven by collaboration with the companies because the companies have the planning platforms and the technology to help surgeons make these complicated plans and to get it right. It can be automated, actually. And it advocates for an automated planning process where if you're going to do a significant spinal fusion and there's a cup in there, the planner measures the cup angle and tells you, if I can tell you the numbers. Right now I can tell you the numbers that put that cup at risk. But the numbers don't mean anything to spine docs. It's maybe a generation before this kind of thing gets put into the standard planning process. But it has to go that way. And the other aspect is this motion preservation that you talk of. I think spine surgeons now know that fusions come at a cost. And especially in the cervical spine, disc replacements, motion preservation has done very well. And to try to bring more of it to the lumbar spine, I think is a admirable project.
You talk about this generational component. It's been a 20-year process, right? And you look at companies like Sentinel and ProDisc. They've put in 250,000 implants, tons of cervical cases. They've got, they are the only lumbar disc on the market, and then you've got new companies that are coming on like Premia, who does a facet replacement. You have companies like 3Spine, who we know very, very well after being able to work with them for the last multiple years. And you have new options that you didn't have before. And I think that's really exciting to see as well, to be able to provide some of those technologies that you didn't have before. You just didn't have the option to do it before, right?
The problem, I call it the Tower of Babel effect, is, as I said, the bodies of knowledge are different. So common language between the two doesn't really exist. So there have been articles that said, well, this speaks to having good discussion between the spine and hip surgeons. But when you get down to what discussion, it always only can come to what hurts most, or is there nerve damage, with the discussion of, well, who do you do first? But it doesn't have to just be that. It can be biomechanical planning for optimal reconstructions and the effect of one part on another part. These all go into incremental gains. The future is all about these gains in operations that work well. And there are almost no elective operations that work better than elective hip replacement, which was called the operation of the century for the 20th century because it worked so well. But there's 10, 15% in which it doesn't. And dislocation is still one of the significant complications.
Hips are the gold standard for when you're doing a total joint, right? I mean, they are patient outcomes are great. We've gotten so much better at them. You can do them faster. But you've got this proportion that still have dislocations. But based on the conversation that we just had, it's almost not a technology failure. It's a failure of adjacent joints. And with this, if the spine is determining some of those dislocations, it's almost not so much what the hip is doing, it's what you're doing to the spine above it, or what's happening biomechanically at the spine.
That's right. We talk in hip surgery about a safe zone. Like, what area can you put the part in that is safe? And people with sagittal spinal imbalance and stiffness, there is no safe zone. There's actually probably 5% where the biomechanics of the hip just, you can't. As I said, there's two sides, the flexion side, the extension side. If you go too much one way, you'll impinge on the other because the mechanics are so bad. So what we've done in hip surgery is we've come out with dual mobility cups that actually make it harder for the hip to come out of joint. It can still impinge because you can't stop the spinal pelvic mechanics. They are not really changed when the spine is a problem. But you can keep the cup in despite impingement with this option. And larger balls on the femur component, the part that goes in the socket, the larger that head, the harder it is to come out of socket. So impingement many times is asymptomatic, doesn't really bother the patient. It has to do more with longevity and durability of the implant. But dislocations is a real problem. So surgeons in the hip world have said, well, we've pretty much solved the dislocation, so we have no problem. We don't need spinal pelvic biomechanics. It doesn't occur for us. But still, there's a lot of revisions for instability despite that. And, it's actually a problem that industry kind of creates that impedes the science and evolution of surgical thinking, because if we have a problem, industry solves it with parts. And the surgeons can do their same thing but it works better. It's pretty cool and it's pretty fascinating.
So you're talking about this process, which I think is so fascinating because I think we see the same thing in spine, right? Where like, I can solve that problem. What's one of the big problems? They've got a flat back, or they got, degeneration, they got sagittal malalignment. And now we have technology that is good enough that we can put you down to a nth degree into the perfect lordosis. That is, the ideal physiologic lordosis. But it's the ideal physiologic lordosis for a snapshot in time, not through a functional plane and functional motion.
So temporal factors, it's huge in the hips as well. And it's age-related. Your whole posture in your life is age-related. You stand differently when you're 20 than when you're 60. So the average age for hip replacements is in the 62 to 65 age. And a normal 62 to 65-year-old person stands differently than a normal 25-year-old. And then on the other end of it, you put your hip replacement in that person at 62 years old. 15 years later, when they're 77, those parts, especially the socket, is not at the same place you put it, because as we age, we decline. Lordosis is lost, the pelvis rolls back, and a cup that was perfect now has more anteversion. And stiffness, of course, is related to age. 40% of people over 75 in just from a stand to sit position would qualify as stiff, which we think of as bad. But a 20-year-old in standing to sitting is stiff. And that's because their femur is normally very active. They don't have to use their spine. That's something else that blew me away. What's normal changes over our life. What's normal in a cohort of spine people or hip patients is different than what's normal for normal human. And it's moving targets as we age. And you can't do anything about that except predictive analytics will have a big impact in this.
And I think looking at the whole body versus continuing to just look at one narrow, to your point, snapshot of the body. Like, we're not going to be able to solve these big problems if we don't have people like you that are saying, hold on, let me take a step back and look at this holistically. I think that's a problem in medicine overall, right? That most of medicine is like, I'm just going to focus on this one thing, especially Western medicine of I'm just going to focus on your symptom versus fixing your symptom versus figuring out why you had the symptom in the first place.
Subspecialization is a two-edged sword.
Yeah.
It's great, but because each silo is so deep, you can just be an expert in that silo, but you've lost the integration.
We talk about that a lot. And with this subspecialization, we're starting to see it a little bit more in spine, where we're seeing guys that are branching out and almost becoming exclusive motion preservation doctors. And it's because, there are so many different options on the market. They move differently. The different types of procedures are different. And those tools work different in different folks' hands, right? But the temporal one is very interesting. So how do you go about doing that problem? So what I'm hearing from you, and I want to distill it and make sure that we're getting this correct, right? Because there's been a lot of information, is that there's a couple of components in the lower lumbar spine that are absolutely essential. One of them is motion, right? Being able to move and move through planes. And then one of them is essentially having the correct lordosis or some amount of lordosis. Are those two things, high priorities for the lumbar spine, especially when it relates to the hips and the pelvis?
I believe that what I'm reading is that people like Alan Daniels and Basil Diebo are working on a per level. The lordosis, the correct angulation or lordosis of each level matters. So in that regard, yes, lordosis is going to matter. Reconstruction, recreation of the correct age-correlated lordosis. and then motion.
I love the word that you used, which is reconstruction, because I think that's an arthroplasty term, right? When you're reconstructing a joint, we're trying to reconstruct it towards a functional component process so that you can utilize it as it was previously, right? And so when I think about this, I mean, being able to have motion through those planes, like you said, motion is something that you can age with, correct? So as you age, your spine is going to change shape and you're going to have kind of a different plane, a different sagittal balance, but your spine can move in response to that, right? If you could put a couple of functional mobile joints in there, the body can at least compensate for those effects, right? Whether the pelvis is moving or how much the pelvis is moving and then the spine is.
Yes. And one question that I just thought of, and we didn't touch on it. We talked that when you sit, you use mostly your lower lumbar spine, which is the L5S1 articulation. If you would measure that, that's sacral slope, which is part of the lumbar lordosis measurement. If you sit and then bend forward to tie your shoes, it's a different mechanism. Now you're flexing your whole spine. It's not erect. You didn't just take an upright trunk and sit. You're bending it forward. That requires the upper portion of the lumbar spine. L1 changes a great deal. So the other part of lumbar lordosis, if you measure L1, you need the upper part to bend forward. And that's how people dislocate a lot too, in flexion. Standing and bending over, or sitting and bending over to get up out of a low seat. So I wonder if upper lumbar treatment with motion preservation, even if you have to fuse below, might address this kind of issue. And we just thought of it right now.
Now you got to go research it, right?
You know what's really funny? You bring up Dr. Daniels and Dr. Debo, and they actually brought up this concept as well. These are two guys that see major deformity cases, right? They see the biggest and the baddest. And so, we talk about fusion a lot. We talk about motion preservation. Fusion isn't going anywhere, right? When you look at tumor and trauma and some of these major deformity cases, it's going to be around because that's the option we have right now. And you do have to stabilize the spine in some of those situations. The question that we have is for those segments that don't have a deformity, and could you treat them with a motion preserving implant? And we know that we can do that now because we can do it with anterior discs, right? We have them for the lumbar. They work great. The question is, can we reconstruct the whole joint, right? And that's why we get really excited that, we've seen a lot of the work that 3Spine's done, and now having a posterior approach total joint replacement that has finished clinical trials. It's going to be interesting to see
what impact that makes.
Well, what you can all do with it, right? So it will absolutely be used as a standalone, and people are going to use it as a joint replacement. But how can you solve some of the problems that are going to be out there regardless, right?
It's a jump because I don't think the spine surgeons are thinking, I'm going to put this disc replacement at L1 or L2 so that patient can bend forward and tie their shoes in a chair, because they don't typically consider those functional poses. And that, again, speaks to my paper where I first introduced the fact that spine surgeons can consider taking lateral seated x-rays for them so they can understand the risk to a hip replacement that's already there.
We talk a lot about, we work with Dr. Scott Hodges, and he's a big fan of yours. And he introduced us to this idea of we're a linkage system. And he does a lot of research too of how is the spine being impacted by the hips and the knees and so forth. And he, for majority of the end of his practice and, through 3Spine, takes x-rays or all images of standing, sitting, and slump sitting. I don't spend all day sitting up. I'm slumping over. There's a lot more impacts and what's happening in all of those different positions that we actually spend our life in, right? To your point, we rarely spend a lot of time standing anymore. We're a sitting society. And so we should really be focused on where are people spending their time. And so how is that impacting what we're doing?
So we use the flex sitting or upright sitting for planning and risk assessment. Absolutely. there are lots of ways to sit. It's much more variable than standing. And that's why some people think you should plan just based on standing, because gravity is gravity. You're standing in it. And you can sit upright 1 minute and slump the next minute. If you understand what the body does, then you can incorporate that in your thinking. Like when you slump, typically your pelvis is going to roll back some more. It doesn't engender dislocation in the hip. I don't know the effect. You'd have to measure sort of the upper levels of a fusion to see, does that cause the stresses that cause failure that I think is the important thing for spine people in other positions than standing, to understand what is influencing the upper end of their constructs. See, they use the word constructs, don't they?
Mm-hmm.
So reconstruction, constructs, it's all the same. The fused area isn't going to change.
Yeah.
But the level above, I think, would get more stress. The level below, the hip, actually, if a young man has a really bad hip, but their spine is still young, the hip is the primary disease, they sit by barely flexing their hip, and their spine hyperflexes. So their pelvis can roll back 45 degrees. Basically, they sit slumped because they can't any other way. And then when you fix them, they won't sit the same way. They can flex their hip more so their pelvis doesn't have to go back. So it's been documented that this phenomena, which we called hypermobility in the hip, goes away when you fix. It's hypermobility of the pelvis, and spine is fixed when you fix the hip. The hip couldn't participate, couldn't work. Now it can. So the mechanics, the body has this way of wanting to get back to homeostasis, to natural movements. It's again in part of this kind of compensation world that goes beyond basic mechanics. That's so absolutely fascinating about studying the human body. At first, I started this so I could learn where to put a cup and get hip replacements better. But I was learning about the human body in ways that nobody seems to know, and because I looked across the junction, I crossed the barrier between hip and spine. And it's been so rewarding for me. And that's why I'm on LinkedIn, and I'm always trying to get my message out. Because, people need to learn and they need to know. Because patients just know, but they can't explain it. They just know,
Well, I think the question is, it's really funny. Where does demand come from, right? Demand comes from one of the aspects that you talk about, right? A business decision. And so we are a capitalist economy, and that's how things work. But demand also comes from a need for change, right? And so things change over time because you could almost argue because of poor outcomes, right? If patients were doing amazing, patients wouldn't demand a change. Nobody would demand a change because the outcomes would be where we are, right? Half the reason that some of this work is occurring, you could argue the entire reason that this work is occurring is because the standard isn't high enough, right? It needs to be better than where it is. And I think that's a fascinating
It's
point
always the outliers. It's always the outliers. They're in joint replacement, they talk 15, 20% knees. In hips, you'd say it'd be much higher overall satisfaction rate. But when you really dig into it, there's still 15% of patients who probably have some issues. So research and, as I said, incremental gains is all about trying to move the needle closer to 100.
As close as you can get to 100.
As close as you can get. But as I said, it's up to more the outside of industry influences to create the buzz or create the knowledge that makes people want to do something different. Like, if you really look critically at a lot of the robotic outcomes in joint replacement surgery, the larger studies are showing no benefit from robotic total joints. One of the things that I argue is that if you don't change your philosophy, if you don't change your operation, and you're just doing the same operation with technology, you won't change the outcomes. That's one. And then the second is, because our components are good, now the timeline to see the difference is much longer. Meaning at 5 years, they don't separate yet. Longevity goes beyond that in people's lives. So a lot of times they do these curves over time, and it's not between 10 and 20 years that you see the divergence. And then it becomes clear that it's like a car tire. At 20,000 miles, they're all good.
Yeah.
At 40, half of them are gone.
Yeah.
It's the same thing. Longevity and durability has to be measured over time. And if you ask a surgeon, what happens 20 years later isn't his problem. It's quite interesting.
We've had that conversation with Pat Warden, Avanesh Pat Warden. He's in Chicago. We've had that conversation with Scott Hodges. We talk about it just, at 3Spine as well, because that truly is the case. We look at like 1 year, 2 year, maybe 5 year outcomes, but a lot of times it starts to diverge at 7 to 10 years. That's still, the patient's still impacted. We should care about that.
Of course, but it's very difficult to get surgeons to feel that means a reason I need to look at things that I do. I might need to change what I'm doing, especially now when everybody's going into ambulatory surgery center. The time frame of results are, where is this person back to work at 10 days? Great operation.
Yeah.
I mean, it's become compressed. So really, you're looking at outcomes at incredibly short time periods.
It's hard because we also are a society of quick. Like, even if we look on LinkedIn, like you mentioned, I love seeing your posts on LinkedIn. I love to see when there's spine posts and then you respond, and you always create really good conversation. But a lot of times it's, x-rays or imaging that's, well, when was this taken? Was this just taken the day after the surgery? Like, how far out are we really considering this a success? Like, how long are we following before we're looking at something and clapping our hands about it,
Yes. Long-term data is what really matters. And we don't really, in 20 years, we're not going to be doing the same things at all. Things change so fast.
We talk about, the concept of treating an x-ray, right? It's like you can treat an x-ray and you can take out the exact component that you wanted to, or restore the exact lordosis that you wanted to. But functionally, how are we measuring that functionally? Return to work is a good short-term metric, right? How can people get back to work? But not just how can they get back to work, what are they getting back to? Right? Are they going back and working, in a field or in a lab? Are they standing all day? Are they sitting in a chair all day? Like, what kind of work? How active can they be? Because those are the parts that matter, right?
We used to do joint replacements on old people, and we don't now. We do them on actually pretty young people with incredible expectations and demands. So that's even another layer to this. What are the ceilings that an operation can do? A hip replacement has a ceiling. There are not professional athletes playing with hip replacements, but there are some with what's called a hip resurfacing, which is a different operation where you don't cut the whole ball off. And so that speaks to evolution of components and operations that actually service a higher level of function, not just pain relief, walking, and sitting. Actually, Armin's group in Utah has that philosophy that they are looking to return spine patients to high function. It's a lofty goal, and they're incredibly good surgeons, and they can take that on. But I think that's kind of novel in in the spine world. And that's why I think Armin is so enthusiastic about his disc replacements and motion-sparing surgery, because function is better. I mean, it's a practice where people seek out those options because they're not old and they still have goals of being very active. And I think all of orthopedic surgery should be moving in that direction. I mean, that's nice to think about a future that could provide that kind of return of function to people.
When you do look at spine, I mean, you look at disc replacements, there are professional athletes that have disc replacements in now and go back to full function, right? I mean, that is a testament to the work that is being done right now.
Mm-hmm.
That's really the future.
These are Armin's cases, right? Dr. Ketchatarian has people traveling from all over the U.S. to fly to to get surgery with him instead of getting surgery locally, so that they can get a 2-level disc replacement or a 3-level disc replacement, a motion preserving option, or, you know, hopefully a total joint replacement here soon in spine. But that's occurring because they heard about the story of their dad or their mom or their grandparent or their friend who had something else done and it wasn't up to standard or up to par.
It's reputation. You know, you get a reputation and you earn it.
Mm-hmm.
You know, these outstanding doctors earn it. I mean, you make choices. And sometimes an outstanding doctor can make a bet on a prosthesis or a procedure that doesn't work out as hoped. But the ones that have the right choice and good results and higher ceilings, people find out and they come. Awareness and education is still incredibly important. And I do feel that before I die, I'm going to teach a lot of people this. This is why I retired from clinical practice. I fell into this. I was 58 years old the time I talked to that engineer the first day, 60 when I had my first paper published. You know, it's never too late. And if you find something that calls to you, follow it. Don't be afraid. I mean, it's a great message for people. Most people still believe that, you know, your creative years are your young years. Well, I proved kind of that that's not it. There's always time if you go for it.
Well, especially when it has such a massive impact on the other side, right? This is a problem that, I mean, truthfully, we've been trying to solve for 40 years. I mean, you talk about this hypothetical safe zone, right? That paper was published back in 1978, right? Like in Lewinick, like you look at this safe zone and now you're essentially refuting this topic 40 years later, you know, in 2020.
So the first paper that Dr. Dorr published with my name on it is the paper that took down the Lewinick zone.
The death of the Lewinick zone.
So the page one was an editorial with Dr. Dorr and the editor of the Journal of Joint Replacement, Arthroplasty, The Death of the Lewinick Zone. Page 3 was our article that showed why the Lewinick zone didn't work, was it didn't consider the femur, it wasn't functional, and femoral hypermobility was the enemy. It wasn't so much where you put your cup, it was the non-modifiable spinal pelvic consequence of a hypermobile femur related to a stiff pelvis. Fantastic. I mean, can you imagine? That's my first paper that I worked with him. I've been given this gift, and one of the greatest surgeons of our time allowed me to flourish with him. And I'm not wasting that opportunity. I'm not stopping.
I can say from our side, like I mentioned, I love reading what you're posting on LinkedIn of what I can, even understand, because it is very complex, but I think you've made such an impact already. And it is a hard thing to go across those lines, but you've done it so successfully so far. And we're so grateful that you would even sit down with us and have this conversation, because it is so important. And at the end of the day, it's about patience, and this information has to get out there so we can continue to move that standard forward for them.
Yeah, I certainly appreciate it. I told my friend, I'm going to tell him, I speak Spanish.
Spanish. So do I. I speak Spanish too.
Yes.
That's a great
And so it's difficult because most hip guys, they're hip. They don't speak Spanish.
Yeah, that's great.
It's funny as you tell that story. I mean, you have a level of humility to you that's incredible, but I would argue that these things don't happen by accident, right? And, you can say you were given a gift, but I think that gift wouldn't be given to anybody, right? It's because you spent your career focused on this aspect.
I mean, for Larry Dorr to actually engage me, I had no validity whatsoever. I'm a guy calling him from nowhere. And second, the gift came from my father, that he was a mechanical engineer, a real engineer. And my mother was an artist. And I was neither. I was a mix of both. But on this topic, his genes came out in force. I was dreaming and seeing the pelvis moving as gears. I produced this concept of the pelvic gear as opposed to the famous Dr. Dubosset's pelvic vertebrae. I said, no, it's a central gear in a 3-gear system with the lumbar spine, the pelvis, and the hip. And the central gear is the key gear. In mechanical engineering, I found out it's called the idler gear. I was dreaming how they were moving together. And then my geometric quest, my research was to find the gear ratios, how the spine moves and the hip moves. It just became a puzzle of human machinery. We are machines. We behave by the same principles. Our skeleton is a structure that does this. I mean, it's been quite a trip. It's a deep rabbit hole.
I love it, but you're mixing that, both sides of your parents, of the art and science that is, healthcare. Like, you have to have a mixture of both to really understand and be able to move things forward.
It's given me some advantages, perhaps. I'm grateful now.
We're grateful.
I mean, to make that connection to your father so late in your life was almost overwhelming,
It's a beautiful thing.
It certainly was.
Again, that doesn't happen by accident, right? Like it's almost funny when it's, hindsight 2020, right? And it's really easy to see like, oh, of course this makes sense. But as you're going through it, it's sometimes tough, right?
It's beyond comprehension.
And I don't know like how because you're someone that put that all together, right? So you've got this artist and this engineer, and it came together, and you've got a little bit of that blend, right?
Yeah.
You've got a little bit of that blend. So when these things come together, there's this, burning passion for you to go out and search for these things. And you happen to run into two of arguably the biggest names in orthopedics, right? Richard Stedman and Larry Dorr. That doesn't happen by accident, right? But then you have to actually move forward and take those concepts and do something with them, right? Because knowledge alone is nothing, right? Action is what moves the world forward, right? So you could go spend time with those guys and say, oh, it's really nice to meet them. It was fun. I'm going to continue doing what I'm doing. But there's something that you needed to trigger. And it was probably partially your mom and partially your dad and partially you. And, unfortunately, Larry Dorr and Richard Stedman are no longer with us, but they still live on, right? But they live on through the people that are doing this work.
We all stand on their shoulders, don't we? I'll share with you that for many years, I'd go to the academy meeting and never go into the lecture halls. I would just wander the trade floors because I felt that's where innovation truly was for me. I could see it, And I don't know what I was looking for. I was looking for something that I could really appreciate and like. And then in 2015, I actually found it. So again, you could say, where does this come from? I mean, like, it was fate. It was meant to happen. You know, it was the right place at the right time with the right guy. You know, the rest is history that's yet to be written. I'm still working on that.
I think it's a beautiful message to anyone in any industry or whatever they're doing of when you're open and you want to find purpose and you're open to it and you're curious, it'll hit you.
Curiosity and an open mind is what drives. That's all innovation comes from an idea, a thought that's outside the established thought. And the only way to have that open is an open mind. What's wonderful is that there's innovation in lots of different ways you can express it. Like you said, there are people who could make things, and they're driven to make parts, gadgets, products. And fabulous innovation. And then there's science. I mean, what I feel that I've learned is actually basic science that should be taught in medical school, but is not. And then I applied it to a clinical problem or clinical problems. But where my innovation intersects with the gadgets is mostly through software, is how to do programs, be it preoperative risk assessment before you even see the surgeon, to surgical planning, to trying to understand predictive analytics to improve things in the future by being able to predict what your body is going to look like in 20 years, and then we'll know what your body needs. This is a very exciting time because it's not just about a surgery and some parts.
Right.
There's lots and lots of new doors opening and new areas to get involved in. Preoperative optimization is very important for spine surgery, just as it is for joint replacement.
Yep.
I'm very interested in preoperative optimizations. That's another area where innovation and creativity and persistence, I think we can do great things with this.
What does that look like? That's what I was going to ask. So you know, age is a number, right? And I think we're sitting down with you here today, and you still got fire in the tank. You have gas and you're ready to go.
You're just that new type of physician, right?
You're pushing that forward. And what is that? What are you excited about that's pushing forward next? Is it, you know, some of the nav and the robotics? Is it the preoperative planning? Is it the data aggregation?
Everything.
It's all of it.
It's called the ecosystem, right? They call it an ecosystem. People at these companies don't, they like to pigeonhole you, I think. I'm a hip planning guy. I know hip spine. I love every absolute part of an ecosystem, from before the patient comes in to 20 years after their procedure is done. It's all about understanding risks and data collection and how to analyze and use that data properly. I mean, how do you get carte blanche? Hi, I'm a visionary, and I want to retool your platform and ecosystem and make it the best on the planet. Okay, we'll get back to you.
You're a spine surgeon, right? Well, no, but I know a lot about spine.
Right. I mean, that's why I say sometimes things really take a long time, and you do what you can and you enjoy the ride, I guess you can. And I'm enjoying the ride. The LinkedIn part has given me a worldwide network of friends, and what a gift that is, as opposed to just saying, okay, I'm 67, I'm going to retire and then just I go to meetings and I am so engaged, and I know so many people and visit so many people's booths and talk with surgeons. I mean, I am more involved than ever in orthopedics. And I mean, it's fantastic.
Well, you're well known. You're well known, and your voice gets out there, and it needs to, right? Because these are questions that need to get answered, and it doesn't happen overnight. It takes time. You know, I think we'd be selling ourselves short if we didn't wrap up with, truthfully, your passion and what you're doing and the work that you're trying to do. Let's look at an ideal world, an ideal biomechanical state of the body. If you're a patient coming in, what are you looking for? So if you've got, you need a hip arthroplasty, something along those lines, what do you need your pelvis to do? What do you need your hips to do? What do you need your spine to do in an ideal world? Because to me, I hear that we need it planned correctly so that you can move through planes, and two, that you can actually move through those planes, right? Because functionally, we want to be able to function and move through sitting and through standing and through bending down. But being able to do that, I mean, in an ideal situation, if you could set it up, if you were a patient having to go in, what are you looking for? What do you want?
Well, you want a proper analysis of what your biomechanics are, and then a plan that best address your individual, personalized mechanics with proper risk assessment. That's what a surgeon's job is for a patient. Make the right diagnosis, discuss the pros and cons of treatments, and discuss the potential complications. And it's all about informed consent and making a decision, because ultimately the decision is on the patient to go ahead with something or not. And the surgeon has to address all the concerns properly. As I said, a lot of that can be done almost on a automated fashion in the future, which is why I'm excited about it. You know, in a perfect world, you'd be able to restore people to a fully mobile, functional person, but that's not always realistic. So doing the best you can, and one that preserves function and still relieves pain and has a reasonable risk profile, is the optimal choice.
And I think we're getting there because of this work, right? You make that point of restoring to essentially what your full mobility or full capacity would be. We're almost there. I think we're getting there, right?
Well,
we're so close.
We're moving in that direction to higher functioning outcomes, or being able to take care of higher functioning people and their demands. I want to be a pickleball champion. I want to climb Mount Kilimanjaro. Oh, I'm a ski instructor and I'm 75, and I want to return to that. I mean, these are things that a generation ago we didn't consider. It's sort of a new world, and I don't know where that change in expectations actually came from. Is it patients? Is it the doctors? Or I think it's both.
Yeah, I think it's a mixture.
I think it's both that have pushed that.
Well, we've heard stories on both sides. It's really interesting when you hear it, because you have patients that have either, one, gone through some of these themselves and say, I don't want to go through that again. Do you have another option? Do you have an alternative option? Or they see friends and family members and loved ones go through it, and they say, I'd like to be able to do more or function better than what I have seen previously. And also, we have access to data that we didn't have before, right? With the advent of the internet and being able to search on Google and look up papers, that wasn't a thing 20 years ago, right? 25 years ago. You had to go to the library, check out a book if you could possibly find it, but that's a big hurdle.
You wouldn't believe what my residency was like. I was always a reader and kind of a pack rat. So if I saw something that I liked or a topic, I would get all the books and take them to a copying machine and press every page
Wow.
on a copying machine, sometimes for hours. Like I'd be on call in the hospital and I'd be burning up their copying machine, copying 200 pages. I mean, the world has certainly changed, hasn't it?
It has.
But because I remember that and I can really appreciate what life is now. I have a virtual library on my phone. 150 tabs of just papers that I can't live without.
Yeah.
The story makes sense now, though. You've got a guy who is sitting there burning through all the paper in the library. It makes sense that you've been able to make the advancements that you have. It's incredible. And to talk about how everything is, I think that's full circle, right? Because how much technology has changed. Well, look how much our care continuum has changed and how much we've learned in the last 25 years. You talk about the patient side demanding change. We hear these same conversations. And again, I'm just speaking on behalf of spine, but some of these surgeons have changed their practices because they're like, I'm so sick of seeing this repeat patient that comes back 3 years later or 5 years later or 7 years later. To your point, you're not seeing them the next day, and 2 weeks later, they might be happy, but 2 weeks later isn't success, right? It's 3 years and 5 years and 10 years down the road. And people at some point get sick of reoperations or sick of patients who are coming in and aren't happy with the standard of care that's getting provided, right?
Let me address one other thing that we talked on a little before. Because hip replacements can relieve back pain, how it works is the hip doesn't work, so the spine becomes hypermobile. Even if it isn't mobile, it's trying. So it's always at the breaking point. I need a little more lordosis so you can sit down. After you fix the hip, then that stresses off the spine. So a lot of spine surgeons really want hip surgery to be done first because then the hip works and then the spine doesn't hurt so much, and some patients go away. They don't need the spine surgery, which is true, especially with people who have hip flexion contractures as a result of their arthritis in their hips. They don't extend their hips all the way. So the extension has to come from the lumbar spine. It's trying to lordose and it's stiff and it's painful. Facets hurt, whatever. So that is one reason that I've heard that blanket statement that some spine surgeons want the hips done first. I can argue the other way. The reality should be understanding both. If the spine surgeon wants to do a large correction, one of the most important papers that came out on this hip spine was back in 2015 when Aaron Buckland and John Vidorchik in New York wrote a paper on spinal deformity patients who had hip replacements and how much change occurred in the hip replacements. And the mean change of the cup was over 5 degrees, which is fairly significant. And I would assume that most of those ASD patients from NYU's database had significant corrections. If the correction is significant, please do your correction first. So it's based on biomechanical principles, not just what hurts more. There's actually some science behind this.
Well, it's interesting when you talk about an inferior adjacent joint, right, with the hips, even with smaller constructs, with single level and 2 level specifically, we know that there is hypermobility at an adjacent level superior, right? And so there's hyperphysiologic loading that occurs through that disc. And so over time, that will make an impact. I'm really curious because it's such a good point. So essentially, you're saying that if you solve the hip, you could solve some of that in spine and realign. Could that be true the other way around? Can you realign some of the spine or reconstruct what is supposed to be functionally normal? And can that also help the hip, vice versa?
What happens when you fix the spine is that you make their posture better. The secondary compensation for spinal imbalance is bending your knees. So your hip flexes. So you walk with soft knees. So that if you think about it, it's like the first stage of sitting down. When you sit down, your butt goes back. So your line of gravity goes back. So after you exhaust the ability of the pelvis to roll back, or sometimes more in men, while that's happening, it's a shared response, the knees will flex. After you fix the spine and correct above, they don't need to do that anymore. So the hip extension can come back, and they stand up better.
So you can correct the spine and help the pelvis and the movement.
The hip forms a better position in standing. It goes back to more normal standing. The knee isn't bent, so it's all connected. When the hip flexes, the knee flexes, and the ankle has to bend. I mean, it's just that's how it happens. So all that can get more normal.
But it's all interconnected. I don't want to lose that point for patients, is that you can treat one of these and it could, fix, impact or affect your other adjacent joints. That's unbelievable.
It's a chain, a kinetic chain. That's all it is. I kind of think of the spine more like a bullwhip, a whip, and a mast. That mast is potted into the pelvis, but it's all connected. You have the bullwhip above, and then you've got this sort of bending movements, and it's mostly flexion and extension we're talking about in the lower extremities. The sagittal plane is the primary plane of function. I mean, flexion and extension. Fine-tuning, I think, axial, and it's important in the spine. The axial plane is the third plane that spine people have gotten to. And Dubussé, again, was near the front on showing the implications of axial plane things in the spine. And it's a little bit in the knees for knee replacement, it's coming. But from my experience, joint replacement has been one plane, AP or coronal plane study to recreate anatomy forever. And then both in spine and in joint replacement, the sagittal plane is getting its due now. And the third plane is the axial plane. But I think from a functional standpoint, the sagittal plane is the key plane. From an anatomic reconstruction plane, especially for the hips and knees, the coronal plane gives you the information to match the anatomy of the patient.
So we talked about the concept of perspective, which I think is amazing. And I think, working to change the paradigm and the perspective of how people are looking at these issues is so important. Earlier we were legitimately going through your notebooks of research, right? Like
handwritten, thick notebook of just really deep diving into the math of all of this.
But your data and your research and the points that you can make, and you can legitimately look through your graphs, right? You can look how a stiff spine changes something, how a stiff standing spine changes something, how a stiff sitting spine changes something. And we talked about this point, right? We know some of these conclusions, right? Which is that fusion constructs, we talk about long fusion constructs and how they can increase the chance of dislocations of the hip, right? They can also increase the wear rates of the hip. But we talk about that on the form of long fusions. We don't talk about it on the form of short fusions. Could you not make the assumption that there is still some amount of added wear or faster wear or increased risk of dislocation, even at a single level or two levels, because we know that there is still hyperphysiologic loads that occur through the spine? Could you not make that assumption? Or is there data that we should be collecting to be looking at that?
I've said for a long time, I think that spine surgeons should collect sitting data for single level, two level, specific level fusions, just to get an understanding of how much motion is lost from each of those. Because it's motion that determines more than anything where hip components should go.
Well, and it's interesting too, because we're not singling out hardware fusions, right? We're just talking about fused elements of the spine or elements of the spine that aren't moving, right? So this could happen from degenerative pathology over time, and stiff spines or, a fused spine, like we talked about, like that can happen without hardware in there. But that doesn't mean that we shouldn't be looking at the outcomes of that the same way.
We don't know how much, in general, an L4 to S1 fusion changes the motion of a pelvis. What's the people who get those procedures, what's their normal preoperative motion? And then after you do the fusion, what is it? And since it's at the lumbosacral junction is the adjacent segment. So that fusion would have the most effect, I believe, on the hip joint. As you go further away, it would have less.
How do you start to actually measure it? Like, how can you start to capture that data?
They have an EOS machine. A lot of people just have them sit. You can do it that way. Or they have standing x-rays. And spine surgeons forever have done standing flexion extension views. Just sit them and take a lateral view.
And see how much they lose in their motion of their spine.
And study, how much mobility of the pelvis is there pre-op and how much it changed post-op. Because if I knew that on average, a patient is going to lose 6 degrees of mobility after their spine fusion, then I could plan that. That's predictive planning, just like we talked about time. I've tried to produce an equation to say if you have 20 degrees of pelvic motion pre-op, 1 year later you'll have 14 because your hip works well. So I'm going to put your hip in the right position for when it works, not preoperatively. So it took nearly a decade, and there is no program available now that does anything like this, that does predictive planning. But I did it for the last, 2 years or more in my surgical practice, that I would try to plan where I believed your hip would be functioning when you got better. And so then it could work that way for a while, but then you would age more and things would change again. So they're moving targets.
Could you make a claim, or maybe not a claim, but based on what we know so far, right, in that immobility of the spine changes, the wear rates and the dislocation rates in the hip, that the possibility of restoring motion to those spinal levels, whether it's L5S1 or L4-5, could have a positive impact on hips and on how the pelvis moves? And
yeah, sure. Anything that brings you more towards normal is good. It would slow the accelerated wear rate in the hip if you restore more motion in the spine.
If we could slow that down and it takes 10 years instead of 3 or 20 years instead of 10, that's a huge difference for patient outcomes, right? And surgical outcomes. And then, you talk about just the monetary, the actual burden of financially on our healthcare system and on individuals. You could get into a whole different rabbit hole with that on how that changes.
Absolutely. In general, medicine treats sickness, doesn't promote wellness. So you can make sort of a corollary towards surgery. It's a short-term fix. And unfortunately, because of the insurance landscape in this country, it's become a volume business. You don't get paid enough to take time. The only way to make a good living is volume. And surgeons are incredibly smart and driven people, and they've learned to actually do huge numbers of cases in a day. And anesthesia has learned how to make people go home without feeling pains. So it all goes towards high volume outpatient surgeries.
This is a fascinating, that is a deep rabbit hole.
That's a whole other rabbit hole, but it's a good point of it. It's such a complex topic that we're talking about. You can go down, deep dive into one section, and there's a whole other group that it's impacting that, we can't even touch, right?
Yeah. It's also why it's fun.
Yeah.
It kind of all goes back to that topic that you brought up about changing people's perspective on even how we treat this, or the way in which we would go about treating it. Because we see this a lot in spine, even without fusion hardware, you can fusions can occur, right? Or immobility can occur. And it's almost like you can get spines that we see this that get really stiff or locked up due to, almost a protective effect, right? Of like, oh, I'm having pain, or we assume that's what's happening, right? That I'm having pain, therefore I'm going to try to become immobile so that those pain generators aren't incurring more pain.
That's right. Like spinal stenosis and spinal stabilization exercises, put yourself in a small zone that is comfortable and be able to maintain that zone, which means give up the rest of the zone that you used to have, but just stay in the area where you can function.
That's an element of sacrificing, right? Like your functional outcomes, your functional ability.
Life is a set of sacrifices and compromises, isn't it?
It sure is. But in other situations, I'm just like, now I'm thinking hypothetically about this, right? If you could go in and you could remove pathology that was causing stiffness in the spine, and you could restore motion, right? Through an implant, through a surgery, through whatever that is, there is reason to believe that you could regain some of that functionality, right? I mean, you take away the pathology, restore motion, and even, reduce like degeneration and wear at adjacent joints, right? Like the hip.
Yes. And again, it's the ceiling. How much motion? How much function? Motion preserving, by definition, should have a higher ceiling than motion sacrificing.
How do you balance, following the data and listening to the data and not compromising on care, but still moving the ball forward, right? Because if we're doing what we did 20 years ago, it is not where we should be, right? I mean, that is kind of one of the worst things we could probably do, is doing the same thing that we're doing 20 years ago.
Being comfortable and being satisfied is never good here. You always have to be looking for better. Never satisfied, never stop learning. And it seemed for quite a while in my career that joint replacements were kind of in a neutral place. They were pretty good, and for years we kind of just did the same thing. And then things began to change, and it's never stopped. I mean, change now is incredible. I mean, it's almost, there's too much information. How do we, ferret this apart to understand what do we need to really focus on and concentrate? There are approximately 8 or 9 alignment theories for putting in a total knee. There are different ideas, different approaches and different kinds of implants and ways that people put their hips in. Spine surgeons, some will attack a problem one way, another way. There's so many options to do things that it takes time. And this is really the indication for good registry data, because the registries shows the outcomes of multiple people across a population doing things and really but they take time to get the right data.
Do you think we'll ever see the point that you made earlier? Do you think we'll ever see knee replacements and or hip replacements in high-performing athletes?
So the hip resurfacing, there are. Andy Riddick in tennis and Patrick Kane playing professional with hip resurfacings that we talked about. A partial knee replacement, where you only have disease on one part of the knee and then you just replace that knee, where most of the anatomy is maintained, they have a higher functional limit, I believe, when they're in right than a total knee does. But it's all evolution, and somebody somewhere is going to come up with a better mousetrap, a better design, and things will progress. I mean, when I started, the average age for a joint replacement was about 72. If they were under 65, no way, that won't last. They stayed in the hospital for 2 weeks after their operation, and half of them got transfused blood.
Wow.
It's so amazing, the strides of that, though. And that's
amazing. We don't always stop and realize that enough either, I'm even just sitting here and like, we should be pushing quicker. And you think about it, but then you go, wait, let's take a minute and realize how far we have actually come.
Absolutely.
It's insane. 2 weeks now, we're like, if you're not out in the same day or within one day, we're like, that's not a success for a lot of surgery, you know?
Well, I was going to say that parallels spine, right? I mean, we saw very similar things in spine where you were expected to be, an inpatient for 3 nights or 4 nights. And now, to your point, you have a lot of people pushing to ASCs. You have people that are getting discharged same day. And that's like almost becoming the standard. And if you're not doing that, people are like, oh, well, why did they stay overnight?
What went wrong?
It's crazy. It's crazy to think about how that's shifted.
Yes. The stuff that ASD surgeons really do, long fusions, those are high risk operations. They have higher complication rates, and those patients should stay in the hospital. I mean, some of this fervor is actually driven by finances again, the financial world. That's just the reality of it. The hospitals get paid to turn the rooms over. They get paid by the diagnosis, and the faster they get them out, the better. Surgeons, likewise, get paid by the case. They're incentivized to do more. Yeah. It's a different world. The surgeons don't do 2 cases a week and play golf on Wednesday anymore. You don't see it very much. It's all about sweet spots, isn't it?
That's exactly right. Because it's funny. The reason I bring that up is, again, it's when you're starting to see more parallels with total joints in knees and hips that you do in spine. Because that's what you're seeing in spine too, is like it used to be, stay off it as much as you can. But now we're realizing like you don't want to be what you'd consider like an overly aggressive rehab, right? But you still want to have motion, right? Like you still want to get mobile. You want to get the muscle envelope moving again, right? Because we have to get the spine back into a situation where it can move and be healthy. That's what we're trying to do, like is restore physiologic function as much as humanly possible.
Even Alan said, what's really interesting is this, how the body readjusts. And sometimes he sees readjustment up to like 2 years after the operation. What he expected to happen as a result of his surgery didn't happen. But then at the 2-year follow-up, it happened.
Takes time.
And some people more time than others. But the body wants to get better. The body is driven by gravity and biomechanical forces. It wants to behave the way it was made to behave. So it's trying to get back as best it can.
Which is to move and to function. And it's, you brought up this point a couple of times, and I think you're absolutely right. And I think we're starting to see this delineation. I almost think there's what you'd consider 2 subgroups of patient populations when you look at spine care, right? And one of them is those major deformity, major trauma, tumor cases where you're doing these huge reconstructions. The truth of the matter is the majority of patients are degenerative cases, right? 1, 2, 3 levels. And it'll be interesting too to see, if you don't wait to treat, if you don't push off treatment as long as you possibly can, you might be able to treat some of those things earlier so they don't progress into deformity cases, right? But it's interesting because, you look at guys like Alan Daniels and Basil Debo, and they are, in terms of research and what they're looking at, what they're paying attention to, the top of their game, right? I mean, they are unbelievable in the data that they're putting out, but it's almost like a totally different subgroup of patients. They're treating this like massive, large, kind of deformity group. And then there's a whole nother amount of research that is being done right now. And that is these kind of like smaller cases, right? Single level, 2 level, 3 level cases.
It's absolutely perfect evolution. So Spine World started this biomechanics stuff to deal with adult scoliosis, deformities. And nobody was thinking about degenerative cases, which are smaller, and hybrid reconstructions, where this level needs to be fused, but I think I can put in a disc here or a level replacement here. That's an idea that, I'm not familiar with, but from a philosophical perspective, it makes total sense.
And I think those are the guys that are going to be testing those, right? Because they have the patient population that's doing a lot of that.
So that International Spine Study Group that they belong to me, is one of the most potent research organizations I've ever seen. I mean, their output and the quality of their work is remarkable. And so you have a champion to drive things. So innovation needs champions.
Mm-hmm.
You rally around a leader for a cause or a reason. That's the way humans are built. So you need to have these people here who can walk the walk and talk the talk and be convincing. And then some people say, okay, I'm with you.
And I actually want you to touch on a component because you have done so much work to impact the spine community, the hip community, patient outcomes, and you've done a lot of philanthropic work as well. And I'd like for you, if you'd willing to touch on it, talk about Operation Walk that you did with Dr. Larry Dorr. I mean, 17,000 patients treated, 25 countries. I think it's really important to hear about.
Yeah, he had that idea. I think after he went to Russia and saw some other humanitarian groups working in different problems, to come back and do joint replacements for people who had no access to it in poorer countries. And so he started this organization with two of his gals from his operating room out in Los Angeles, and it has spread to maybe 25 or so organizations within Operation Walk. He invited me in 2019 to go with the LA-based group to Cuba, and we did about 50 to 60 joint replacements, I think, in 3 days of operating. And it's so pure. The people are so appreciative. There's nobody who goes on these missions that thinks that they didn't get more back personally themselves than what they did. It's one of the greatest experiences. And I always have been part of a humanitarian bent. In 95, I went to People's Republic of China and volunteered in a hospital with a group called Orthopedics Overseas, in a new hospital in a city that was trying to do Western medicine, Western-based medicine. I spent 4 weeks there, and it was a fantastic experience. It's just hard. The cultural exchange, camaraderie, and relationships you build with the doctors there. I mean, it's amazingly good for the soul and spirit to be involved in humanitarian work within your field.
We've talked a little bit about legacy and your legacy living on past, when you're here and when other folks are here. I mean, I think it's a testament to the work that Dr. Dorr did and so many other people who have helped out with that, to be able to provide no-cost care, and that it's still lived, I mean, what is it, almost 25 years later that he started that, and now it's grown to what it is. I mean, that is a testament to a lot of the topics that we've been talking about, right? Is like something that lives on beyond when you're here to provide value.
He changed so many people's lives. It's absolutely remarkable. I mean, my story seems unusual. There's 100 stories like mine of being involved with Larry Dorr. It was a special guy and a tremendous contributor to orthopedic knowledge, not only this humanitarian thing. He was a force of nature, this guy.
I think we can all be, appreciative and grateful when those forces come into our life, right? Because we all get them. I mean, we all get them. And I think you've been fortunate enough to be able to recognize them and carry on the legacy, right? I think we all hope that when something like that comes along, that we can jump on board and continue to recognize it when it happens.
That's the key. These opportunities flit before us, everybody. And half the time, you didn't recognize it, and it's gone. So being open and aware, being your own advocate, and kind of understanding and taking a moment to think, which is hard because we're all so busy and doing things, to recognize something that may be impactful within all this noise that we're bombarded with every day. one person can change the world. And it's just a matter of how much impact each change has.
Whether it's God or creator or faith or whatever it is, I think we all have that thing, right? And to your point, sometimes it takes, 10 years or 20 years or 30 years to find, but that doesn't mean it's not out there, right? It's being able to recognize that and seeing what that passion is and what
being open to it.
Yes.
I mean, some people are happy with whatever. Life can be difficult. I haven't had a difficult life. I consider it a luxury that I could look for these passion things, that I didn't have to worry about ill health or financial problems. Or life is a tough road for a lot of people. So this is part of what I'm grateful for.
It means a lot to us, and we're very appreciative to be able to come here and sit down with you, and you host us here in your beautiful home. It's been a lot of fun.
Well, it's my pleasure.
We've been very fortunate, and I'm glad that we had visitors too. We had Leo came and join us. And
Great time with Leo. We should have asked him his perspective on this.
We got to see Leo, and we got to meet Allie and Max and everybody around, and we appreciate you and Nancy having us here. So thank you so much for taking the time. For people that are continuing to find your work and look for you and want to continue following you, is LinkedIn the best place to follow you, or where can people consume your information? This is advertising.
We are the hashtag bod squad. Wow.
This is the best.
You're just bringing this up.
Hashtag follow the bod and join the bod squad.
The best pitch we've seen, the best closing pitch we've seen. I will say, now that you've shown us, we're going to need t-shirts before we get out of here. So,
but I will say, I've said it a couple times, but I'm going to reiterate it again. Following you on LinkedIn, if you are interested, even as a patient, but if you are in the spine space at all, hip space, you are a must follow on LinkedIn just to see where you're going and commenting and what you post yourself. You are really making an impact there. And it's really, really educational and also very entertaining to be able to follow and see what you're chatting about on LinkedIn.
Thank you very much.
Well, we appreciate it. I don't think this is going to be the last time we sit down with you. So we appreciate you taking the time, and hopefully we'll see you again soon. Thank you so much, Dr. Russell Bodner.
Thank you.
See you soon.